Good afternoon. Thank you for attending the Preparing for Mission Lifeline EMS Recognition 2025 Recognition webinar. My name is Alex Kuhn, and I'm an American Heart Association EMS consultant. Before we begin, we'd like to start and go over a few items we'd like the participants to know today. The webinar is being recorded and will be sent out via email within the next 48 hours. The slides, if you're interested in, are in the handout pane. There are no CEs associated with this webinar. However, there is an opportunity to download a certificate of attendance if you want to, and that will be available at the end. If you experience any technical issues during the presentation, most can be resolved by refreshing your browser. If issues are not resolved by refreshing your browser, please refer to GoToWebinar registration confirmation email with instructions for checking your system requirements for participation. You can submit questions by typing them into the question pane on the control pane at any point during the webinar. Time allowing, we will go over some of those questions, and if not, then we will email you the answers as soon as we can. With that, let's begin. So today, we are going to cover a couple things related to Mission Lifeline EMS recognition. First, we're going to go over a quick review of 2024. And then talk about the 2025 measures. We have two great guest speakers from Columbus, Ohio, who are going to talk a little bit about how EMS and hospitals work together on improving stroke care and outcomes. And then we're just going to cover at the end the 2025 process and where we are in the release of the 2025 measures and QCT for 2025. So the 2024 measures and 2025 measure update. First and foremost, we had 546 agencies that were recognized this year. We had about 800 that applied. Several of them did not get recognition, mostly because there were some volume issues and low numbers, but we are working on with those agencies for next year. As you can see, agencies from just about every state in the United States has a recognized agency. Again, Ohio, Pennsylvania, Delaware, or Virginia, and Texas had the most, and that's usually just because they have a lot of agencies in those states.
Hey, Alex.
Hey, Alex, I'm not seeing.
Oh,
we're not seeing your slides. Just your video.
Yeah,
you look great, but we need to see the slides. There we go.
Perfect. I'm looking at me. I'm failing already. My bad, everybody. Got to hit the share button. So. Again, 546 agencies across the United States, with Texas, Pennsylvania, and Florida having the most. Thank you, Jason, for letting me know that. We have begun working on 2025 measures and getting ready to release those 2025 measures, but just so you understand how those measures are developed, they are based on AHA guidelines for heart attack and stroke. There is an EMS task force that works with the AHA on going through those guidelines and developing each of the measures. We have tried to align our measures with criteria in the NEMSIS data values, as well as trying to harmonize some of our measures with the Get With The Guidelines hospital data and their measures. And of course, we always take feedback from folks that have participated in the program and different working groups and volunteer groups as we look at these measures from year to year to year. For 2025, for the Mission Lifeline EMS Recognition Award, the 7 measures that you used last year if you applied are going to be the same measures that we use this year. So there are no changes to the Mission Lifeline EMS recognition measures for this year. We have made some additional changes to some of the other measures, and I'm going to go through these right now. We will have 2 optional reporting measures this year. One is AHA 6B, which is aspirin administration for suspected heart attack. We are in the process of sunsetting AHA EMS 6, which is aspirin for STEMI positive ECGs. This should align more with which our protocols are for giving aspirin in the field. We also have AHA EMS 11, which is EMS first medical contact endovascular therapy within 120 minutes for patients with stroke, and there will be an extended transport opportunity there. So if you happen to be outside of that window of 120 minutes and you have a long transport and you're taking patients to a hospital that does endovascular, there will be an opportunity to include those patients. We wanted to plan on having that as a target stroke award this year, but our volunteers felt it was probably a little too soon. About 30% of patients nationally are meeting that criteria as of 2024, get with the guideline stroke data. We did make some changes to the target heart attack measure. As you will see, we added an extended transport window. So I know many of the agencies may not be within 30 minutes, 40 minutes of a hospital that does primary PCI, but they still bypass closer hospitals to go to hospitals that do primary PCI. So if you are outside of 45 minutes for a drive time, you will have 120 minutes for the extended drive time for this measure. So it's EMS first medical contact to primary PCI within 90 minutes, which we've been doing for the past several years, or if the EMS first medical contact time is less than or equal to 120 minutes when the transport time is greater than or equal to 45 minutes, then you will have an additional time there. We also have updated AHA EMS 9. The old measure used to talk about door to lytics within 30 minutes. It is now updated to say EMS first medical contact to lytics within 60 minutes for STEMI patients. We are now taking into account the EMS component for patients that are going to hospitals that will receive lytics. Coming down here, we have, again, one of the other changes that we've made here is that you still are required to have 4 STEMI annually to be eligible for the Get With the Guidelines Target Heart Attack Award. This year, different than last year, you only have to submit data for one measure. You either have to do AHA EMS 8 or AHA EMS 9. So it used to be last year you would have to submit data for both. We found a lot of agencies struggled and got confused with trying to enter data for both. And some agencies would put the exact same numerator and denominator for both measures. And what we found is just going to be easier to do one measure or the other for patients that are having STEMIs and either getting lytics or primary percutaneous coronary intervention. New this year, we are adding a stroke systems of care measure, AHA EMS 10, and this is EMS first medical contact to fibrillate therapy within 90 minutes for stroke patients. You must have 4 patients annually to be eligible for this award, and the threshold is 50% for recognition. And I got a bullet out of place up there that 88% is tied to this award here. So 88% of patients have an EMS first medical contact to lytics within 90 minutes. So according to Get With the Guidelines into 2024 so far. So we're hoping more agencies will continue to work on systems of care with their hospital as we continue to roll out these systems of care measures for stroke. Just to kind of show you what it's going to kind of look like this year, different than last year. So measures 1 through 7 will kind of look the same. Measures 8, you'll have the opportunity to select whether you want to enter those measures or not. So you can select or not select to enter those measures. And then again, you only have to enter measures 8 or measure 9. Same is true for 10. You do not have to enter those. So you can select that box or unselect that box. And then same for the optional measures below. We're really excited about adding the Target Stroke EMS Systems Award this year. Lots of great work happening around stroke systems of care around nationally. We think this will help drive some of the care and quality improvement processes that go on between EMS and hospitals. And I have 2 guest speakers, Dr. Rob Lowe, who is the medical director from Columbus Fire Department, and Sharon Heaton, who is the administrative director for the neurology department and trauma and burn department. If I get that wrong, Sharon, at the Ohio State Wexner Medical Center, who are going to talk a little bit about EMS and hospital work here in Columbus. I'm going to pass it over to Dr. Lowe.
Well, thanks. It's a pleasure to be here. Maybe a little bit humbling at times. When we do these things, we want to make sure that that we're giving you good information, but sometimes I have to kind of own the fact that this is always a learning process for us as well. And so my promise to you today as I step through these slides is to kind of own where we've either struggled a little bit or we found an area for challenge and ultimately improvement and things like that. So Alex, do you advance the slides or does that work for me?
I will advance the slide for you.
Go ahead. All right, so real quick, I just pulled a couple of quick things from the guidelines to illustrate some things we've done or some things we've struggled with, and then kind of what we do as, quote, a learning system and how we do that, how we take the feedback we get from our various institutions, including Ohio State and Sharon's group, and to go from there. So with that, let's just dive into the next slide. Within the EMS section of the guidelines, there's a little bit of a focus here on public education, some of the protocols. We'll step through each of those and I'll kind of highlight some things that we try to do or some measures we try to improve upon and go from there. So you can go ahead to the next one. So public education for EMS, you would think this lives in our wheelhouse, especially as a fire-based EMS service. And yet this is something that I think we always strive to try to improve upon. Our hospital systems, quite frankly, are a lot better at this. And so partnering with our hospital systems, I know guidelines talk a lot about partnering with public health, and that's certainly important too, but the infrastructure of some of our hospital systems. And we're going to talk about primary kind of response and stroke today. We do have some unique pilot programs that go on here, and that ability to meet with our hospital partners, our stroke programs, kind of all at the same time and all in the same room has really helped bring us to the table in the public education aspect, as well as we've talked about how we get materials out to target certain non-English speaking populations, certain areas of town and things like that. So definitely something that the partnership builds upon. And that we needed a little bit of extra help just getting to full speed on that like we do with our clinical things. So you can go ahead to the next slide. I don't know if mine's not advancing. Did you advance? All right. Assessment of stroke severity. So locally we use the LAMS. That's something that EMS and the hospitals kind of got together with, and several years ago just kind of came up on a system where we could all agree that EMS would be using this, and the hospitals all kind of understood that that's just the capability we felt the most comfortable using, whether that be the literature that was available at the time, the ability, the reproducibility from our folks and things like that. And we're fortunate that we live in a system that has both primary and comprehensive level cares, and so we can easily make that decision. And so locally for us, a 4 or 5 being predictive of a large vessel occlusion allows us to hit a bypass to go to our more comprehensive, our endovascular capable facilities. Next slide. Protocols for identifying stroke. And you may look at this and say, hey, that's kind of out of order. Really, shouldn't this be in the other order? And that's intentional because when we first sort of kicked this in several years ago, this was an area where we tripped up a little bit. Our protocols for identifying stroke was something that we felt initially we did pretty well. We had a very a very complete patient assessment, and within that patient assessment, our primary and secondary assessments and our neuro assessments, and we felt like that was our method for identifying stroke. And unfortunately, we discovered pretty quickly that there's the reason the guidelines are the guidelines. And by stepping back a little bit and saying we need a stroke identification tool separate from a stroke severity tool became pretty obvious to us as a system. Just to remind folks as they ended up into that sort of pathway, kind of to get things rapidly moving and not get bogged down in a long assessment and get a little bit lost in the assessment as well. And so the reason I switched these is because that was kind of the order we developed in. We got very good at when we knew it was a stroke at doing the assessment, but sometimes we were missing some of the things on the identifying the stroke because the assessment tool focused so much on motor and trying to find the large vessel that sometimes we would miss the atypical symptoms. That's obviously something that is an ongoing process always with identifying strokes. I know those of you who work in hospitals, the idea of dizziness and things like that are a little bit more challenging for us as well, and the same can be true of our pre-hospital providers. Next slide. 911 screening. This honestly is an area where I think EMS in general has some work to do. And that's because most of us use national standards and dispatch protocols. We have recently switched one of the big national providers to a different big national provider. And the reason I say there's work to be done here is we're really good in EMS about saying how fast we need to go out the door, but we have an over triage that exceeds anything we see out in medicine. And so we run out the door a lot on suspected strokes. The positive predictive value of that is not always super high, and that's probably where the area of the most work can be done. We initially tried to qualify these as highly suspicious, moderately suspicious, things like that, and it just wasn't real good. We were either stroke or not stroke from dispatch, and had to work on that. So that's something, as we've switched dispatch softwares, we've begun to have the ability now to tailor our questions and tailor our screening from dispatch. And we're hopeful that that's going to give us a little bit better insight into our ability to more positively predict stroke and to send the appropriate resources without over triaging all of our folks. Next slide. I threw this slide in, so I promised you I would be somewhat transparent. This was when you started hearing the guidelines and you start looking at things like that, this is something where you can get a lot of support. And so we locally had a little bit of a situation where we had comprehensive centers, and then we had some centers that had some ability coming online of endovascular, but time frame in transports really didn't exceed this 15-minute rule thing. And so being able as a medical director to say, hey, we're going to adhere to a national guideline here that says we're going to still bypass you for the comprehensive because it's within our 15-minute guideline here, helped us quite a bit in tamping down those conversations, or at least having those conversations remain very patient-centered and nonpartisan. So a lot of benefit to that. In working through our destination protocols and our transport protocols. Next slide. And then pre-arrival notification, this is actually something I think our crews are pretty empowered at. I would imagine in your systems that's like that as well. If you live within trauma systems and STEMI systems and then stroke systems, they all kind of build on each other. The empowering of the crew to make the call, and when they're unsure, to still own that as well, to just own to the hospital like, hey, I'm suspicious, this is why I'm suspicious, and to communicate the concerns. The other thing we've been pretty good at is our crew as advocates. And so occasionally, when you just do 150,000 transports a year, you're going to bump into situations where maybe there's a misunderstanding or a misdirection on arrival for crews to vocally advocate on behalf of the patient. No, we're concerned that this is a stroke. We actually should, think about this destination within your facility and things like that. And those have always been received pretty well. We've had fantastic hospital partners who appreciate the crews giving them insight or filling in those missing pieces. So much appreciated from our hospital partners. And again, something I feel like we do fairly well. Next slide. So what's a learning system look like for us? Ultimately, it comes down to many ways to communicate. We've been building out our quality improvement structure within our office at FHIR, within the office of the medical director. That's helped quite a bit in the communication. But regular meetings, our ability to see our stroke partners often in the same meeting was a huge benefit for us. We have a trauma system where trauma leadership all gets in the room with EMS at the same time. And as we began to build that out in the stroke world, hugely beneficial to more rapidly just build on the successes of each system's experiences and incorporate that in EMS, and to standardize across our hospital systems helped quite a bit. Being able to use standard language in reports, or just standard expectations of what was going to happen on arrival and things like that. So that's been pretty good for us. With the next slide, I'll go into that a little bit more. And then how do we receive those feedbacks? We get individual cases, and I think Sharon will show you an example of one of those, what we call one-pagers. We also have at least one of our healthcare systems that's using our data exchange to get feedbacks. Those have been very interesting and helpful to us, just in the sense that they give the crews the ability to look up outcomes on their own patients and educate and build their experience base as well. Next slide. Next slide there, Alex. Yeah. Well, a little bit of a funny system there. Just to give you one final thing, how we do this, this is kind of my previous background before I got into medicine was in engineering. And so I always talk about systems level and system performance kind of things. For us at the individual level, so when crews have a case, I think number one is reinforcing good practice and when they make good calls and good catches, individual corrections as needed, but more importantly, I think system level. And that's where this continual feedback makes a difference by coming through a standardized process at the EMS system for us at the Office of the Medical Director, because we're able to pick up on things that maybe are first indicative of system issues. Do we have a protocol issue where crews in different parts of town are having the same difficulties or misses? Are we seeing a triage issue? Are we seeing a handoff issue? Is there something we're not communicating? Is there something being lost in that? And just how the system performs for us is hugely important. And so anytime we get that feedback where there's an opportunity for improvement, that's one of the first things we ask ourselves is, how does this not happen to the next crew? Is this at a system level or was this really at an individual? And you'll be amazed at how many of those you find at system levels when you really dig into it. So for me, it's always, what did we set you up to do from our office? Is the protocol correct? Is there a gap there? Did we oversimplify something that made it tougher for the crew? And so that's kind of how we approach that. Next slide. And that's really sort of my 10,000 foot view on how we utilize guidelines and how we strive for the constant aspect of improvement. And with that, I'll go off camera.
Thank you, Dr. Lowe. I've got a couple of questions I'll ask you at the end of the presentation, but thank you for presenting. Sharon, you're up.
Good afternoon, everyone. I'm really excited to be here today to talk to you guys about what I call the stroke world. I live the STEMI world. I started the STEMI program here at Ohio State with Dr. Mazzaferri back in 2008. Worked through a lot of this that we're talking about now on the heart side, and very excited to be part of the stroke world with this. I am a nurse by trade. I've been a nurse for a really long time. I was a flight nurse also for 31 years. And so EMS is near and dear to my heart, has always been near and dear to my heart. So I'm going to talk to you guys a little bit about what we as hospital systems should be doing to facilitate care for stroke patients and to collaborate and work with our EMS colleagues. Next slide, Alex. The Ohio State University Medical Center is the only academic medical center within Central Ohio. We are a very large institution and getting larger. Next slide, Alex. In 18 months, we will be opening up our new hospital. It's very large, and we were talking before this webinar, how are we going to staff it? Well, we're not sure about that yet. But one of the real exciting things about this new building is that we are going to have 2 hybrid operating rooms where we will do all of our stroke interventions, both for ischemic and hemorrhagic strokes, and to treat all of our aneurysms. And our neurocritical care unit and our stroke floor will all be one. And so all of our patients will be cohorted in the same areas, and we're very excited about that. Next slide, Alex. In looking at Ohio State and the Wexner Medical Center, we've been a comprehensive stroke center since 2012, and that's when the Joint Commission started certifying hospitals as comprehensive centers. We have the largest independent telestroke network in the state of Ohio. And then we have a sister hospital 5 miles down the road, which is East Hospital, and they've been a PSC, or a primary stroke center, since 2018. When Dr. Lowe mentioned the numbers, he didn't really give you the numbers of stroke centers that we have in Central Ohio. We use our outer belt as kind of a reference to the city of Columbus. And within that outer belt, there are 3 comprehensive centers, and there are about 5 primary centers. So every hospital within the city of Columbus is certified either as a primary or a comprehensive stroke center, which is really great. The one thing that I will say that in Central Ohio, it's a great place to have a stroke. Our EMS agencies are phenomenal at diagnosing. They're not supposed to diagnose, but detecting these patients with stroke, getting them to the appropriate facilities, getting them the care they need, and doing pre-notification, which is integral to what we do. Next slide, Alex. Again, Ohio State has been receiving the Get With the Guidelines awards at the highest level since 2014, when we were first eligible to receive these awards, and have been in good standing with the American Heart Association and have worked a little bit on Mission Lifeline in the past, and looking forward to getting more involved. Go ahead, Alex. So when I talk about the largest independent telestroke network, we have 31 hospitals within our network. When I say independent, it's because we don't own any of them. These are just affiliated with us through mutual agreement to provide telestroke services to them. So in looking at our stroke volumes, about 75% of our patients do come from our network hospitals. The other 25% of our volume come through our emergency department, either by EMS or by private vehicle. And what we are finding is our trend is going up significantly on patients arriving by EMS. And in the last quarter, we were close to 60% of our patients that had arrived by EMS. So I think the collaboration that has happened between the Columbus Fire Department and the adult health systems here in the city of Columbus has really helped to do that public education piece and getting people to call 911. Go ahead, Alex. The biggest thing that hospitals have to understand when you're a comprehensive center or a primary center and you are working with your EMS agencies, it is imperative that you take the lead on working with those hospitals to educate the EMS, to work with the systems, the health systems that are there, and to provide recognition. So for example, at Ohio State, we are very involved in our telestroke community. So Worcester Community Hospital, highly involved in their community and spreading the word about stroke. Working with MedFlight of Ohio, who is our transport partner here at Ohio State and at Ohio Health, to provide education out in the region. And then the last picture on this slide, this is actually an EMS agency that transported a patient to Worcester Community Hospital. Worcester Community Hospital sits in a rural community in northeastern Ohio, a lot of Amish, very rural, and a lot of volunteer fire departments. This particular fire department was being recognized for their part in a 17-minute door-to-needle time in this small community hospital utilizing telestroke. And the reason this could happen is because EMS agencies are really good at what they do. They pre-notified Worcester. Worcester Hospital has a direct-to-CT protocol, and the patient received IV lytics within 17 minutes. So that is huge. It is really important that we really work with our EMS and recognize them as partners and share our successes with them. What's also important is to be transparent. If you have a bad door-to-needle time, if you have a bad door-to-groin time, you just tell them why. It's really important. We provide 100% feedback to all of our EMS agencies and transferring hospitals on every stroke patient brought in to be evaluated for stroke. We pride ourselves in that. I have a 60% FTE dedicated to just doing that in the stroke world, which has been tremendously successful. We don't have to get a call to ask us for the information. Jenna is really good at getting it out in front of even the request for that information. The other thing hospitals can really do to help collaborate, especially if you are the comprehensive center or the thrombectomy capable center, is invite the EMS to stay, watch the CT, watch the CT angiogram, watch your process. Now we know that sometimes they can't go all the way through to intervention. Sometimes it's just limited by their ability to be out of service. But really to explain things to them and understand, our nurse practitioners and our residents go out of their way to keep the EMS in CT scan, to explain things to them. And it has been very successful in really beginning to build those collaborative bonds and understanding. Go ahead, Alex. One of the things that Ohio State prides themselves in is that we were the first Central Ohio hospital to do direct-to-cath lab for STEMI 24/7. Obviously, that was a long time ago, and we still do it. But we were also the first Central Ohio hospital to offer direct to CT 24/7 for any suspected stroke patient. This has been highly successful at decreasing our times. It is really important that we do that. About 80% of our patients that come in by EMS do come by Columbus Fire. The rest are brought into us by various other township agencies close to Ohio State. We do on occasion have some field activations from rural communities by helicopter, but we still take all of those patients directly to CT scan. Go ahead, Alex. When we are receiving pre-notification, and what we have seen with our data over the last 10 years, is that when these patients arrive by EMS, it really does impact your door-to times. And this is going to then impact those EMS times that we're going to start looking at. We have seen a decrease in about 50% in our door to CT start times. So if you think about it, a patient comes into triage, walks in, gets dropped off, whatever the case may be. They have to go through whatever intake process. I was at an ED the other day and I had to go through a metal detector and see security before I could even tell them what was wrong with me. That's the same way here at Ohio State. You go through the metal detector and then you see a provider. So when you think about that, they hit the door and then they get triaged and then, oh crap, this is a stroke patient. And then you got to find a wheelchair because you got to try to get them to CT scan. And it really can cause some delays. But when EMS pre-notify us and let us know they're coming, they are met in CT scan by the entire team. So a neurology resident or APP, an ED resident, pharmacist, nurses, techs, respiratory therapy is there in the case the patient needs some respiratory assistance. And the only step between coming off the EMS cot to the CT scanner is we'll put them on a bed to weigh them. It's a Joint Commission requirement that we make sure we get weights on all of our patients that potentially could receive IV lytics. So that is really the only minute delay is to actually weigh them. So we've seen a decrease in our door to CT times by about 50%. We have seen a door to needle time decrease by about 15 minutes. Our fastest case was 8 minutes door to needle time. And like I said, Worcester Community Hospital, actually at that celebration that I spoke about, they had 2 cases where they were celebrating 17-minute door to needle times with EMS pre-notification. So this doesn't just work in big cities. This can work in small communities and with small community hospitals. And as the leader with our 31 telestroke sites, we work very closely with them on EMS education, on doing direct to CT, on switching lytics from TPA to TNK so that administration times can be quicker. So we take our responsibility as the CSC or the telestroke site very, very seriously. And then the other time that we look at very carefully is our door to groin times, or if a patient needs to go to intervention for an LVO, the goal is to get, if it's a transfer patient, door to groin in less than 60 minutes. And if a patient presents directly to the ED by private vehicle or by EMS, that we achieve door to groin in less than 90 minutes. And what we have seen is that this can really decrease our time by 20 minutes or more. And our fastest door to groin was 25 minutes. That included getting CT angiogram, getting TNK, and getting upstairs to the OR for their thrombectomy. So that was another pre-hospital notification. We were told that the patient was a stroke. We were told their last known normal. We were told they had a LAMS of 5 with a severe gaze deviation, and that was very indicative to us. And so calls were made, the OR was cleared, and just on that information from the EMS, we were able to expedite that patient's care tremendously. Go ahead, Alex. So last week we had a case where we had I think she was 52-year-old, 51-year-old patient. Columbus Fire was dispatched on a seizure at about 11:30 at night. And I was reading through the POR chart. They actually got delayed because of a train by about 2 minutes. They got on scene and the patient actually had not had a seizure. She was confused. She was aphasic. She had an arm drift. She had a facial droop. And the LAMS of 5 was documented right away. One of the biggest things EMS agencies can do for hospitals is put an 18-gauge IV catheter in, if at all humanly possible. we have to get a CT angiogram to diagnose a large vessel occlusion. And we can use the 20 gauge hospital or 20 gauge IVs we have in the hospital. They'll take the volume, but EMS don't necessarily carry those. So we do really ask to get that 18 gauge IV in. It will save a lot of time, but don't delay transport getting the patient to the hospital. Door to CT start on this patient after pre-notification was 10 minutes. Door to case request. That is something that we measure as an internal metric. Case request triggers activation of the operating room, and this was after midnight, so it also triggers calling in the team. Now, because we do all of our stroke interventions in the operating room, and because we are a level 1 trauma center as well as all of the other things that we do here, we have a staff in-house that can start the case. They could get the patient upstairs, the fellow goes up with the patient. The attending is here usually within 15 to 20 minutes because they live pretty close. This patient received door to groin in 60 minutes, which is a great time. Our goal is less than 90, and this was after midnight. And when we start talking about that first medical contact, or we used to do this for STEMI, eye to eye, when you saw the patient, it was less than 90 minutes. And that is really the goal to systems of care, is to get that patient, number one, to call 911, get 911 there quickly, EMS, realize what's happening, notify the hospital quickly, get the patient in, get them diagnosed, and get them to definitive treatment. This patient had an NIH, if you're familiar with that, that's what we use to assess stroke, of 22. She was discharged to home with an NIH of 6 to be followed up with outpatient therapy. So this is a huge win in this case. Next slide. And we talked a little bit about feedback. We used to provide a really pretty PowerPoint slide with things all over it. It was a large file. Sometimes it didn't get through to EMS. So they just want things written out. So this is an example of a feedback report that was sent to Columbus Fire on a 51-year-old female. And unfortunately, our strokes have been very young lately. And you know, this is the same lady. She was discharged with the NIH of 6. But they did find that she had an ascending aortic thrombus, and that's where her stroke originated from. So we were able to take care of that, and we will go ahead and continue to have her see cardiology. But then also as part of this feedback report, Alex, if you'd like to go to the next slide, we try to provide some visual representation of what happened. So the MCA occlusion on the left, you can see down towards the bottom, there's a thrombus there with an occluded vessel, and then once it's opened with TICI-2B revascularization. So we do try to provide those types of things. If we get a patient in that's a hemorrhagic stroke, many times we will also send pictures of the hemorrhage. We will also, if we have an aneurysm rupture, we will send these same clips of pre and post aneurysm repair. Any type of intervention that's done, we try to share that information with our EMS colleagues. We take this a little bit further. We actually do this to all of our referring hospitals, and then we also include transport. So if ground transport or air transport was involved, they also get the information. And what we encourage our spoke hospitals to do is if that patient was brought in by EMS, that they turn around and share that information with their EMS. Or if we know who it was, then we will share that information with them. Next slide, Alex. This can't be done without a lot of people and a lot of resources. These are our vascular neurologists. At Ohio State, we admit all of our stroke patients to either vascular trained and certified neurologist neurocritical care or to neurosurgeons if they're surgical. Next slide, Alex. We have 5, well, we have 4 going to 5. We had Huey, Dewey, and Louie, as I lovingly call them. Dr. Nimji, Dr. Powers, and Dr. Yusuf have been with us since 2014. Dr. Powers a little longer. We are onboarding currently Jennifer Kim, and then in January, Vicki Schuneman will be coming back to us. She was one of our residents and left us for fellowship for intervention. So we are very well staffed with interventionalists to provide this care to our patients, and we're very excited to add Dr. Kim and Dr. Schuneman. Next slide, Alex. I think one of our best kept secrets is our APPs. Our advanced practice providers are in our ED every day until about 5 p.m. They have the shortest door to needle times compared to the residents. They have the shortest door to intervention times, but they do this all day, every day. Our residents are on stroke for a month, and then they go to epilepsy, or they go to MS or movement disorders. And so we're very pleased to have a wonderful complement of advanced practice providers who have specialized in stroke to be our partners. These are the ones that truly embrace our EMS and want to work very closely with them. They will grab them, they'll pull them in, they'll show them the CT scans, they'll show them what's going on with the patient. And it's just a really good example of how to collaborate with your EMS colleagues in your area to really form that bond and to really solidify that system of care. Alex, next slide. And that's all I have.
Thank you, Sharon.
Sure.
I'm going to ask a couple questions now while I have you guys on. And a couple questions that came in. You talked a little bit about pre-notification. One question that came in is, were you able to make a thrombolytic decision based on EMS vitals and blood sugars? You know, we touched a little bit about LAMS for large vessel, but how do you make decisions better for patients that are going to go down the thrombolytic trail? And I'll leave that to both you and Dr. Lowe.
So, I'm not Dr. Lowe. I'm really Sharon, even though it says I'm Dr. Lowe. I got promoted today. Yay. You know, for us and Dr. Lowe can help with this too, as much information as possible. Are they on an antithrombotic? Are they on some sort of a blood thinner? And when was the last time they took it? Also, what was the last known normal? That's the big caveat. That's the real difficult thing to decide. Sometimes it changes. Well, a lot of times it changes. And so the EMS do their best to get it quickly. Sometimes the patient gets there and then we get additional information that it was longer out or shorter time frame. Those are the two big things for us, aside from blood glucose, as to thrombolytic administration.
Another question that came in, obviously there's been a lot of literature out there about different stroke severity scales. It seems like every day I read that there's a new one out there. You know, how do you feel about LAMS as it compares to RACE and frankly any of the other ones, whether it's FAST-ED, VAN, whatever new ones come, BFAST, whatever the new one is today that's being published?
Yeah, so I'll jump on that from the pre-hospital side, and then we'll see what Sharon's opinion is from the hospital side. I think in the pre-hospital, we have a game of, it's almost your risk benefit, but it's your balance of reproducibility and speed with accuracy. So the ability to teach an NIH and get that done in the field and get it done accurately really isn't fathomable, right? So what we need is the ability that I have a rapid score that is easily rolled off the brain, rolled off the tongue, that doesn't require a lot of looking up things, but is reproducible from medic to medic. And so several years ago, we just landed on LAMS because at the time it had some literature that sort of backed up its predictability in large vessel. And we combined that with the fact that we could teach it. It was easily remembered. And I have 1,700 providers, about 500 frontline paramedics. So the ability to just reproduce that, I think, was the most important thing to us. It was consistent. It gave us a fairly consistent answer. And it played that game of speed versus accuracy.
Yeah, and I agree with that. I think one of the biggest things is pick one and stick to it. That's the first thing, and because then everybody's learning it the same. But I think what's important, especially from a systems of care perspective, is I can't have Columbus Fire calling in a LAMS and Whitehall calling in a RACE and somebody else calling in a BFAST and my staff isn't going to know what's going on, right? They're not going to learn all of those or what they mean. So it's really important that as a system, you come together and you decide on what you want to use for your system. So all of the hospitals in Central Ohio, all of the EMS, we are all using the same thing. So we're all speaking the same language. And I think that's what's most important.
Yes, agree.
So we have a question, and Sharon, this may be a good one for you. We have an agency that's more in a rural area. They have several EDs that are close, but their closest cath lab and stroke facility is about an hour away. You know, I guess the question is it better to go there for the CT and the care, and then transfer them if needed, a little bit, how does rural agencies fit into this equation, especially with air and, there's challenge with getting ground transportation with EMS not being able to leave, 911 EMS agencies not being able to leave counties or metropolitan or municipal areas. I've run into that a lot.
Yeah, this is a real tough one. And, being a former flight nurse, I get it. I even had someone who called me and said I got in trouble for flying somebody, but it was really the right thing to do. I think you have to know your hospitals and their capabilities. So if they have tele capabilities and they can administer thrombolytics, that is the still tried and true treatment for patients with last known well of less than 4.5 hours. Then you get into that sticky wicket. Well, if it's over 4.5 hours, there's nothing they can do for this patient except transfer, and all you're going to do is delay care if you take them to the hospital to transfer them. If they're on Coumadin, no, I'm not going to even say Coumadin. If they're on Eliquis or Xarelto and they just took it, they're not eligible for thrombolytics. So there's a lot of things that come into play in that. And I would say it's best to, number one, know what your hospital has, what their capabilities are, and work with them to determine who should be flown, who shouldn't be flown, who should be direct transferred. Because there are going to be, if you're allowed to leave your county and you're allowed to drive that hour, if you have someone with a LAMS of 5 who is 12 hours into their last known normal, that community hospital can't do anything but potentially the CT-CTA and then have to turn around and transfer them. So is it better to transport them the hour? It could be. It just depends on what you can do, what your EMS agency has available. But sometimes you can't deplete your resources either. I mean, if you're in the rural community and you're you're not going to really have that option. So it's just investigating and figuring out what you can do. And again, hospitals and this comprehensive centers who work with the local hospitals can really work with you, your EMS medical director, to come up with some decision-making trees that can help you with those decisions.
This is a great question. And do you have a couple, I'm going to ask this a couple different ways here. Sharon, you shared your feedback form. Do you get similar feedback forms from the other 2 health systems here in Central Ohio, Dr. Lowe? And I'm curious, and I saw yours, Sharon, the information you provided, what information is most important to you, Dr. Lowe, when you get those feedback forms?
So we do get similar from all of our folks. It's similar in the STEMI world as well. So that is nice because there's a similarity of information. I would say what's most important to me is sometimes different than what's most important to my providers as well. And that sort of highlights the importance of both groups getting to see the feedback directly. So the provider wants to know, hey, was I right? What happened to my patient, what downstream, and is there anything that where I feel like as a provider, I could have tightened things up a little bit, I could have sped things up. What's important for us in the office, while those things matter, are also more the systems kind of things, like did we hit our benchmarks? Was there pieces that we left out, either in that report or in that history taken, last known wells and glucoses and things like that? And then just destination decisions. Was it an appropriate destination based on LAMS? Was it an appropriate destination based on other factors, whether patient preferences? We don't want to get into long debates on our scenes because, as Sharon pointed out, with a lot of hospitals, we don't want to waste valuable time moving and doing those things. And then the last thing I kind of look at, which sometimes I think our systems get busy and taking care of folks and kind of forget, is how early or late was that pre-notification. We don't want to be doing a pre-notification from the exit on the freeway. We want that to happening at the house or as we're coming out of the house or as we're getting en route, because those 3, 4, 5, 7 minutes can make a huge difference in assembling the team on the backside.
Excellent. I think that's it for questions.
Alex, one thing I'll add, that we're very blessed in the city of Columbus to have great hospitals, to have great stroke centers. But I think what we're most blessed to have is we have 3 adult healthcare systems that are competitors who really look at this from a programmatic standpoint as a collaboration. We look at it as how, as health systems, can we all work together to provide great stroke care for our community. Last spring, the Columbus Clippers is our AAA ball team, and there was a strikeout stroke event that was held there, and it was all the health systems and the American Heart Association all together in one place talking about stroke. And I feel very proud of my team and very proud of my colleagues at the other hospitals who have come together. One thing we didn't touch on in this webinar, and it's a whole different ballgame and a topic for discussion later, but we do have a mobile stroke treatment unit in the city of Columbus, and it is owned and operated by Ohio Health, who is our direct competitor. But it's painted red, white, and blue, and it has Columbus Fire on the side of it, and it has all of our logos on it, and we all collaborate on that mobile stroke treatment unit to provide the best care to the citizens of our area. And we meet regularly as a working group. We meet, some of us meet larger as more an executive group. And it has been, I think, one of the best things that we have done to bring our teams together to support our community as a whole. And I think it's really important that communities do that. Competition is not something that is fun, and you don't want it to impact your patient care. So the more you can work together, the better.
Sharon, that and Dr. Lowe, this actually bring me on to another question. If you're an EMS provider and you're in a community where you're not getting feedback and not hearing outcomes, or you're having struggle with one hospital using one stroke severity and another hospital using a different stroke severity and having different pre-activation and strategies for getting patients to the CT quickly, any thoughts or suggestions for those folks that are, dealing with that? And I'm sure there are several.
Yeah, well, I think it begins with conversation, and it begins with each of those conversations starting with the patient first, right? So even in choosing that score, it's patient first. Now that getting the patient first may be, hey, this is the thing we're able to get you most reliably, or we're able to get you quickly, but it's all in the sense of what do we need for the patient. And for the most part, I think you can talk folks into feedback pretty regularly. Once they start to have, if they have a concern about a single run, then you tell them, hey, I want to be seeing this feedback on a regular basis. Thank you for giving me that, but I need to see them all because I need to see when this is an outlier and how much of an outlier it is. So.
Well, and I think what's important too is if you're a certified stroke center, DNV, Joint Commission, doesn't matter who you are. That's one of the things they want to see. They want to see that you've collaborated with your EMS, that you're providing them feedback, that you're working with them. If you are working with verified stroke centers in your area, they all have a stroke coordinator because they have to. And I think EMS really can help be the driver of that information. They can be the driver of, I can't be doing a LAMS or a race because it's what you want. We need to get together as a group, and getting those stroke coordinators in a room. Stroke coordinators are amazing people, and they're less politically involved in the organization as a whole for the most part, and they can be a little bit more neutral. And so you get those people together in a room, and then they can take it back to their folks at their organization and say, we have to help our EMS colleagues. We're making it difficult for them. And I think EMS can really drive a lot of that difference.
And I will just put one quick plug in here that any of the hospitals that do participate in Get With The Guidelines Stroke, there is a pre-hospital layer that they can turn on to collect pre-hospital data that will provide a lot of this data back to hospitals as part of their feedback. And at some point, and it may already have happened, there is a built-in feedback form in Get With The Guidelines that hospitals can use. So
I think that already exists. Yeah, I think that exists. We don't use it. We need to look at it because that might be better for us.
Yep. So, well, thank you. I'm going to finish up the presentation here and see if I can make sure to get everybody off here in 7 minutes. But thank you, Sharon and Dr. Lowe, for participating today. It's always great working with you here in Columbus. So quickly, updates on 2025. Just a few timeline and next steps things for folks on the phone and for the American Heart Association. We are in the process for folks that participated last year of moving our QCT agencies over from 2024 to 2025. Our vendor that's working on this has told me it will be ready by November. So beginning in November, we will make that move over. That doesn't mean you'll be able to enter data yet, but all the agencies that are currently at a 2024 status for recognition will get moved over to 2025. I do have about 25 agencies that after we close the 2024 recognition signed up, and they're kind of in a pending mode. If you are one of those agencies, as soon as this moves over to 2025, I will approve those pending agencies. We are looking at, oops, I hit the button prematurely. We are looking at December and January of having updated materials and the website available. Additionally, we are working with vendors to sign agreements that will allow them to take our measures officially and build into their platforms our measure set. And so if you have one of those vendors and you see that they are a compatible vendor and they have AHA EMS1, then you will know that based on what our measure criteria is, that whatever you are running is accurate based on that measure criteria. February 2025 is when we anticipate opening up the application. And we also plan on doing some additional webinars. And of course, we are always around to provide agency assistance. So for agencies that participated last year, at this point, one of the things that we are asking you to do is go in and add additional members. We've had several agencies already that the person who filled out the initial QCT has been moved in a different job. And really, it's best practice probably have 2 or 3 individuals in which measures AHA EMS 1 through 7 are exactly the same as last year. The only changes this year are the optional measures, as well as some small changes to the target heart attack and the new target stroke award. And with that, I am going to end our call. With any questions that are still remaining, I will follow up with those individually. Thank you so much for coming. Look forward to working with you next year on measure and being recognized.
Thanks, Alex.
Mm-hmm.